Welcome to Project Echo Geriatrics. I am Kate Bennett. I'm the medical director for Project Echo Geriatrics at the University of Washington, which is part of our Northwest Geriatrics Workforce Enhancement Center. And I start off, before I introduce our speaker, I'll start off with some good news, which is that our center just found out this month that we received funding for another 5 years. And so we will continue on. And Echo will continue year-round as it does the third Friday of every month. It has since 2016, and it will continue on in the next academic year. I want to recognize that this is a very busy time for many of you. There are a lot of transitions happening from resident out to practicing clinician, people graduating from school, people finishing all sorts of traineeships. Those of you who are faculty or in leadership or work with trainees in clinical settings, there are a lot of changes that happen between June and July. So thanks for taking the time with us today to talk about improving the care of older adults. We'll go ahead and I'll introduce our, well, is there anyone who is about to graduate or just graduated and happened to join? If you can, oh, congratulations. That's amazing. Dr. Labib, you are presenting a case and graduating. That's amazing.
Thank you so much. It's an honor to be here with you all.
So glad. Well, thank you. Congratulations. Anybody else? I see a room full of people over there. Anyone graduating? Yes, congratulations. Doesn't it feel good? It's a lot of hard work that goes into all of that. So congratulations to everyone. We just celebrated our fellow graduation last night. They're still working for a bit longer, but we celebrated them. It's good to take time to celebrate milestones. All right. I'm going to introduce our speaker, who is wonderful, and I thank you, Michael, for being our speaker for the last session of this academic year. You're all going to really learn a lot. So Michael Light is a social worker by training and spends his time in palliative care mainly. He's the co-director of the UW Palliative Care Training Center. And one of his great areas of expertise and a way that he's made tremendous impact on the community in Seattle and for UW Medicine is with the homeless palliative care program. And he has a lot of expertise in caring for those with serious illness, including many older adults who are facing housing insecurity, and going out to the community to make sure folks have the best care possible and have what they need to thrive and live their best lives. And there's a lot we have to learn from you, Michael. So I'm so glad you're taking the time out of your busy day. And Michael is I think on vacation and taking time to teach us. So I really appreciate you doing that. And I'm looking forward to hearing what you have to say.
Thanks for the introduction. Can folks hear me okay? Hopefully sound will be okay. I'm presenting from a Starbucks in the middle of a campionship. So it's great to be here. I am Michael Light, social worker with Homeless Palliative Care Team and co-director of UW Palliative Care Training Center. It's really great. Thank you so much, Kate, for the invitation. And it's so nice to meet all of you, and congratulations to folks in life transitions and work transitions. I'm going to try to move through a bunch of like context setting stuff around some of the work in older adults and homelessness and serious illness, like the line of life and practice from the sort of serious illness palliative care side. And then I was trying to sort of think about like what is the one thing I kind of want to focus on in terms of like skills or ways to sort of like think about care in serving older adults for really any adult that's unhoused or really any human. So that's going to be a little bit of a, I'll try to apply to the context so we can have enough time for conversation as well. I really invite your questions. I always say from this work, if you are providing healthcare, you're serving folks who are unhoused. And if you're serving folks who are unhoused, you're actually doing a problem with it. So this is work that we all share. I just got to live with that in a section. So I also want to start by really naming and owning my positionality within this work and really understanding and appreciating in this space as we all have the opportunity to, that my identity is really shaped me, but also my biases, and that shapes my care. So my worldview, my experience, and also my activity. And with that, there's often a lot of difference in the experience that I have with my patients. So I remember and hold here that I have outsider status and also positions of power in the dynamics. And I realize that I'm talking about experiences that I have some experience around, but like most of that experience I'm professional and wisdom for our patients who are living this experience every day are not present here. Recognizing that privilege and power. And to recognize that within all of these various identities, people who have shared identities with me have caused a lot of systemically and individually in practice. So just knowing that those things are all true as we start to think about our care and really, I think it's important level setting. I'm going to say, if you want more information, I'm not going to talk all about my program today. If you want information, we have a website. It's got information about what we do, or referrals, donations, press, publications. So you're welcome to do that. There'll be a link in the slides later. And also, I did have the privilege of presenting to for the Adult Hero series earlier this year. So if you'd like an expanded version, I think this is a 90-minute presentation. You're welcome to go and view that as recorded online. So this gives you sort of time. What I wanted to really start about is sort of thinking about the context of homelessness as well. I feel like of all the slides that I've tried to cut for a 15-minute presentation, I really still want to start by saying that we need to remember that homelessness is really the manifestation of our collective values and moral choices that are codified in policies which cause and allow marginalized and resourceless to be able to find. So to remember that these are choices that we have made as a society, that individuals might have life experiences or things that they have done that contribute to their experience of homelessness, but it's a choice of society and our policy decisions that allow people to experience homelessness and continue to experience this. So when we're thinking about all of this work, we need to keep that in mind, because it's part of our shared responsibility of political framing that most people think about. And while that's multi-systemic and reaches across incarceration, education, all of services, not just housing, we realize that those systemic factors have an impact on the individuals. When we think about individual impact, we can also think of individual health risks that are associated with living unhoused, especially so thinking about not just substance abuse, but homelessness, but exposure to elements, like disease, hygiene outfits, healthcare access, nutrition, and also the experience of violence. And that's the direct experience of violence that people are at increased risk of when they're living outside or living sheltered or unsheltered in their communities, and the exposure to violence as well. So just holding all of these things, and I think we can all imagine some of the ways that this shows up in our clinical spaces, including increased risk of communicable disease. Thinking about things like hygiene if you can't keep wounds, and think about nutrition if you have diabetes or uncertain disease. How do you actually, with limited resources and often forced into services where you have limited choice, limited agency, and what your options are, how do you manage not just survival, but trying to maintain your life? So the health risks are pretty significant when we think about folks who are unhoused. And there's lots of work, and there's even some slides, I think, in my longer presentation about how to provide basic healthcare services. And there's lots of resources for that. We also want to think, again, my lens on serious illness and palliative care, about morbidity and mortality related to those health risks. And really, we've got an increased risk of the rate of illness, hospitalization, traumatic brain injury, but also some of the treatable and preventable conditions like cancer and heart disease, like mortality risk is significantly higher. Think about people who are getting later stage diagnoses and have more limited access to treatment. When we think about the overall mortality for folks who are living chronically unhoused, it's like 8 to 16 times than the general population, the highest for folks who are sheltered. So not only the help with their outcomes related to those health risks. And so one of the things we say in our program is a reminder that the experience of homelessness itself, especially chronic homelessness, is in itself unlikely. When we're thinking about homeless healthcare, it's sort of hard to separate this idea of palliative care. And I think that there's an integrated piece of that to remember in the primary palliative care interventions for all of our patients, especially with chronic homelessness. When we think about that mortality, I think the piece that I want to break down and leave you with is the average age of death for someone who's living chronically unhoused in the community is about 48 to 52, depending on the research over there. And to contextualize that a little bit further, is that that's about the average life expectancy for a white male in the United States between the year 1900. So 100 years plus of medical advances doesn't necessarily change the health outcomes or the mortality risk for someone who doesn't have access to those services. We have so many other encumbrance their ability to meet. When we think about, go ahead. Please.
Michael, I'm sorry, your audio is a little bit muffled. If you're able to talk just a little bit louder,
Yeah.
closer to your microphone, I think it'll help.
Yeah,
Thanks.
absolutely.
Awesome, thank you.
Is this a little bit better?
That's great, thank you.
Great, I'll try to maintain that. So with this context, I also think a lot about homelessness and aging. So I appreciate this is a geriatric space. So thinking about those health risks and thinking about the outcomes, it's one of the reasons that the research around what is considered an older life was actually adjusted for folks who are unhoused down to 50 and older instead of the traditional 65. And part of that is around geriatric conditions. People who get over the age of 50 tend to present with some of the same sort of like geriatric related health concerns that we might see for the general population in some ways, memory loss, falls, and that cohort of people who is over the age of 50 and living unhoused is actually expected to increase by 2030 by about 3 times, and that was pre-COVID expectations and numbers. So that's maybe going to jump higher. Basically to say that we are expecting more people who are older adults to experience homelessness, increased health risk, have more significant concerns, and that population of folks is expected to grow. The thing I'm going to add just with this is to think about the experience of loss and the interrelatedness of the experiences of loss that people have from their experience of homelessness, aging, and life. There are lots of different things that people like lose beyond just possessions, beyond just life, autonomy, agency, freedom, sense of control. There's a lot of loss wrapped up in all of these experiences and a lot of trauma. So I'm going to leave you the context setting with what I'm hoping is that you will be a little bit more worried and slightly more worried for folks who are living unhoused and earlier in their healthcare journey. So thinking about in 15 minutes that I could sort of try to distill what I wanted to communicate and share like some practice strategies. I really wanted to focus today on just some components of relationship-based care. Because this is the cornerstone, I think, of where we always come back to in our practice. And what I think is most effective, it is the pathway to all avenues of clinical care. In order to provide good physical care, I think relationship building needs to be important. And so I was trying to break this down. There is a nursing model of care delivery that's called relationship-based care. This is not that. This is me trying to break down just some categorical ideas around what is contextualized relationship-based care. So I'm calling the social support surrogate services. So I'm just going to run through those quickly. Would love to have some questions afterwards. On the social support side, when you're thinking about building this framework for relationships, part of it is really understanding the social history, including the important people that are in someone's network. We tend to think about people who are unhoused, and in some contexts, they're considered unaccompanied patients. We also tend to think about people as homeless as not having a sense of home. And what's true for many of our folks, there is really a sense of place and community for many of our folks. They might be kind of loners in the world. They might not have a lot of connections, but it's really important to know what those connections are and do deeper histories than where do they sit and what's their sense. So I'm really encouraging you to think about a slightly broader sense of a social history that really understands who are the people in the world and how do the people that they're functioning around really impact their care. So their care, their healthcare decisions, their needs. What are the barriers and facilitators that that community might be able to create? And also really considering legacy and reconnection. When we think about those forms of loss and the trauma that many of our folks who are living unhoused may have, sometimes there really is, I haven't talked to my family in 20 years. If we're really thinking about more worried sooner, if we're helping people think about what are their bigger life goals that are going to be more meaningful to them sometimes than medication that we can offer, sometimes that sense of legacy and helping people prepare, understand that they might get very seriously ill soon, and think about what things that they want to spend their time doing. Sometimes that is reconnection with their social, surrogates. My real call here is to appreciating that many of our folks, when I have a group of outreach healthcare providers in a room and say the National Healthcare for the Homeless Conference, and I say, would you be surprised if everyone on your panel might be dead within the next year? Folks tend to agree that most of the people that they were worried could have a significant change in their healthcare. We're waiting for that sort of looming crisis, and it could come suddenly. It could come very unexpectedly. So being able to understand that even if someone doesn't have a robust social network, being able to prepare a little bit in advance for who's going to make decisions, who do you want to help? This is really an opportunity to think about agency. So really knowing your state's surrogacy laws, so you can then have an honest conversation to try and provide some agency and autonomy for your patient about who is going to be involved in their care. I think this is a really who do you care about? Who knows you? Do you actually know who I'm a social worker. I worked in the emergency department at Harborview for many years. I will find people even who have been talking in 20 years, even if they don't know anything more. So helping people have some autonomy in this process and then documenting what their wishes are and then making sure the documents are saved. Services. There are relationships outside of just social relationships, and many of our patients sometimes have connections to a large network of different service professionals. And it's important to document, identify who those folks are, and then engage in that. Those are the folks that often understand the barriers and facilitators to basic healthcare, sometimes in a way that they can communicate around and plan around that our patients have a hard time doing. So they're going to be often pivotal in making sure that the care that we're trying to provide, the recommendations we have, are reality tested and reasonable and appropriate, and going to fit with a person's overall care needs. Those are individuals that might really facilitate care in the. So understanding who those are, whether it's case managers, mental health providers, behavioral health providers, substance use providers, whoever is in that network, being able to do a little extra communication and planning, drawing that expertise in, collaborating any new connections that might be needed. Often our patients are not well service connected until they get sick. And that is our opportunity then to sort of say, you need more support now. How do we connect you in to more support? And the last piece I'll say is really thinking about self. So there is the social network out here, there's surrogate decisions, there are services, but really understanding that you as a clinician, part of why I say this is you are the person that's best positioned to have and hold a relationship with this facilitating healthcare for this individual that you might be working with. And while you might not be able to change health outcomes, you might not change health behaviors, you might not be able to change or provide all the resources and services. You probably can't get someone housing. You certainly not do it. But what you can do is be along for that journey and lean into the moral distress of what it means to serve someone that there aren't enough resources and you live in society that's allowed them to live outside without support. Leaning into that with cultural humility and care. That is actually what's going to facilitate, I think, the meaning and the purpose that people come to healthcare for. And hopefully help us sustain in this work in situations that seem impossible and seem really overwhelming. With services, social supports, surrogates, and remembering that you are a big part of this relationship as well. And frankly, it's often the most meaningful. It's the thing that you have the most power to control. So I'll just give a little bit of context, sort of think about where this comes together. An example of a generic patient, John, is an amalgamation of some folks who we work with. really understand that social history is not just a person with a healthcare issue or like multiple comorbidities. It's a person who used to hot trains around the country and has lots of great stories around that. Was an arborist, loves being outside, plays the piano, hasn't had family contact in many, many years. But even that brief social history can be a really great ploy for like would never want to be in the hospital like long term, loves the outdoors and his independence so much. I have some sense of his values. It's a foyer for conversation about values and priorities and preferences. A person that camps with a friend of 10 years, which you don't necessarily know unless you're trying to understand that social network, that's the person that visits in the hospital, gets him food, provides some caregiving support, is maybe also a barrier to housing because he wants to stay in the encampment with that person. They can't be housed together. What's the point? That's the person that maybe should join for another clinic visit, or maybe is as a power of attorney. So the case managers they work with, that's the person that's actually going to give them appointment reminders, or maybe even get them. I was also the person so like, you know what, actually, I've noticed that he's stopped taking his medications and he's like walking a bit less. The things our patients might not say, that someone who's seen someone out in the world in a different way can provide better contextual information for how we provide care. Making sure that the social work connected who's like maybe going to do some of the family connection referral to substance use care, bringing in team care and making sure that we're not trying to do any of this alone. And that all of this becomes possible when we get a trusted relationship allows a conversation about trauma history, worries about violence, and expressions of gratitude, a willingness to come back to our clinic in the first place. So the power of relationship-based care really facilitates the care itself. So that's the point that I'm trying to make. To you, that's the case that I'm making. And I think I'm certainly 15 minutes. I would love if there's any questions or thoughts. Please come off mic.